Hi, I'm Ronald Natale, Professor of Medicine, Division of Hematology Oncology, and Director of the Lung Cancer Clinical Research Program, Samuel Ocean Comprehensive Cancer Institute, Cedars-Sinai Medical Center in Los Angeles. I've been invited by Dr. George Shou to present a lecture on immunotherapies for lung cancer and lung toxicities for the California Thoracic Society. These are my disclosures. There will be 260,000 new cases of lung cancer in the United States this year. 85% are the non-small cell lung cancer, 12% small cell lung cancer, and about 2 to 3% carcinoids. Non-small cell lung cancer can be further subdivided into adenocarcinoma, the dominant histologic subtype, squamous cell carcinoma, carcinoma not otherwise specified, and 10% with large cell undifferentiated or high-grade carcinoma. Small cell lung cancer is a distinct histopathologic entity of its own, and carcinoids can be broken down into 10% that are intermediate grade or atypical carcinoids and 90% low-grade carcinoids. I'd like to begin with an anecdotal story of Catalina Island bison herd. Many of you are familiar with the island of Catalina that's off the southern coast of Southern California. 14 American bison were brought to Catalina Island for the 1924 silent film version of Zane Grey's Western tale, The Vanishing American. The herd that was left behind grew to over 600, but began to dwindle to less than 200 and appear sickly due to inbreeding. 59 mostly male bison were added over 60 years, improving herd genetics, and the population grew to over 500. Hundreds were transported to the South Dakota Rosebud Reservation, run by the Lakota tribe, and birth control has been introduced to maintain the herd between 150 and 200. Well, what is the point here? The point is that genetic diversity is the key to survival. With that introduction, this slide demonstrates the prevalence of somatic mutations across 30 human cancer subtypes. From left to right, you see the increasing number of mutations per megabase of DNA, from the low on the left to high on the right, and at the extreme far right of this slide, you can see that malignant melanoma, squamous or adenocarcinoma of the lung, and there in fifth place, small cell lung cancer, all have very high mutational tumor burdens. In the case of lung cancer, sometimes going up to nearly 1,000 mutations per megabase of DNA. Well, the hypothesis that we will explore today is that the high mutational rate and genomic diversity of lung cancer allows it to successfully adapt to environmental pressures, such as chemotherapy and especially our immune systems, in order to survive. This adaptation has many parallels to the natural world of evolutionary biology, especially the dynamics of predator versus prey. We will examine in depth some of the breakthroughs in manipulating our immune system for more effective control of lung cancer. The tumor burden among lung adenocarcinoma can be subdivided into two types. First of all, a subtype that occurs in non-smokers, which constitute about 15% of the overall population, where the mutational rate, in fact, is quite low. It overlaps a little bit with the lower end of the mutational rate that occurs among smokers, the dominant form of lung cancer in the United States, that can be well over 100 mutations per megabase and sometimes up to 1,000 mutations. Well, let's look at two mutationally divergent herds of cancer. Acute myeloblastic leukemia, the far left, with a low mutational burden relative to lung cancer, the high mutational subtype among smokers on the far right. And let's ask the question, what happens when these two mutationally divergent herds are attacked by a single, and I will say moderately weak predator, namely chemotherapy? Well, with AML treated with chemotherapy, 75 to 80% of patients will achieve a major objective response, many of them complete responses with no evidence of leukemic cells on serial bone marrow biopsies, leading to a 50 to 60% 5-year survival in this rapidly proliferating malignancy. Lung cancer, on the other hand, treated with the best chemotherapy developed, platinum-based doublets, only 30 to 35% of patients have an objective response, tumor remission with treatment. In almost all cases, it's a response. And the duration is short, so that only 50% of patients will even 1 year. Well, as the number of mutations or antigens increase, called adaptive immune suppression, cancers, lung cancer in particular, gains the capacity to exploit immune checkpoints to block immune surveillance and attack. Now, this is a fairly sophisticated concept of a non-cognitive disease, lung cancer, appearing to have the cognitive ability to adapt to immune suppression. Well, it requires no cognition at all. It occurs in nature around us all the time. What this is that cancer cells, perhaps because of the mutations that accrue, can inactivate attacking T cells by producing PDL-1 and PDL-2 that you can see in the cartoon, bind to the PD-1 receptor on T cells, the programmed death receptor, and these produce death depicted by the black T cell that has been killed by the PDL-1 or PDL-2 produced by the pink tumor cell in the right side of this cartoon. PDL-1 and PDL-2 have normal functions. They regulate immune response by normally minimizing damage to bystander tissue, and they prevent autoimmunity by promoting self-tolerance. Well, this concept of adaptation, there are many examples in the natural world, such as these owls that adapted to living in the tree trunk, hidden by their color, or this unusual-looking fox that developed long legs so that it could just peer above the grasses of the Serengeti in Africa to see its prey, and perhaps more importantly, to keep an eye on its predators. Or to the Cretaceous Palagine extinction event, in which the meteor eliminated predators, dinosaurs, and changed the environment by transformation of a temperate rainforest, complete loss of the canopy in which birds could fly and feed, into semi-arid deserts, leading to loss of flight in the large birds called ratites. In this case, why fly when you can walk to your next meal and there's nobody around to assault you? Well, there have been 4 drug companies in the United States that have developed anti-PD-1 or PDL-1 antibodies. Phase 1 and 2 trials established the dosages that could be administered intravenously over an hour every 2, 3, or 4 weeks, and Phase 3 trials established the effectiveness of these agents in treating various stages of lung cancer, both small cell and non-small cell. Let's go back and see how this story evolved. This is the KEYNOTE-001 Phase 1-1B clinical trial of Pembrolizumab in the treatment of patients with non-small cell lung cancer. It selected patients with either 3B or most of them stage 4 disease, good ECOG performance status, archival tissue that could be retrieved for examining PD-L1 expression, excluded patients with various autoimmune processes, and accrued 495 patients who were randomized 1-to-1 to receive either 3 milligrams per kilogram of Pembrolizumab every 3 weeks or 10 milligrams per kilogram every 3 weeks. The primary endpoints were safety, the side effect profile, and the objective response rate. I'd like to point out that 94 of these patients had no prior chemotherapy. These patients had to have been informed that standard platinum-based chemotherapy could triple or quadruple their overall 1-year, 2-year survival compared to no treatment, versus entering a Phase 1 clinical trial with a promising immunotherapy drug that yet had unproven efficacy and not completely described toxicity. Well, this slide demonstrates the immunohistochemical stains that were done in concert with this clinical trial, identifying patients who had no IHC staining, identified as PS, PD-L1 score less than 1%, an intermediate group that had a PD-L1 score of 1 to 49% of cancer cells that stained positively, or in the far right column, a PD-L1 score of 50% or higher. Now, we learned in this study and others that were ongoing at the time that with this antibody and other antibodies that were being tested to try to identify functional PDL-1 or PDL-2, that tumors can be in fact quite geographically heterogeneous. Here's an example of a tumor specimen with tissue from two distinct geographic sites that are only angstroms away from each other, in which none of the tumor cells stained for PD-L1 expression, and on the bottom panel, over 50% stained strongly for PD-L1 expression. So one of the problems we recognized early on in these studies is that PD-L1 expression was not going to be a highly reliable predictive marker, because zero expression could be just the hazards of sampling error, and that perhaps the molecule could work in some patients. This slide summarizes the data from KEYNOTE 001. Notice that in patients that had no PD-L1 expression, there was still 8.1% of patients who had an objective response to treatment. When you look at the group that was in the range of 1 to 49%, we have about 17% that had an objective response to this immune checkpoint inhibitor. And finally, in patients that had very high PD-L1 scores, greater than 50%, there were about 40% of patients that had an objective response to treatment. Well, because of the inadequacies of PD-L1 or its inaccuracy in predicting outcome, we've continuously looked for other predictive biomarkers. We recognize that high tumor mutational burden could rationally explain why some cancers are able to avoid immune suppression by production of PD-L1 or PD-L2. And this was one of the first attempts at looking at that. And you can see that there appeared to be a relationship between high tumor mutational burden, 13.8 or more mutations per megabase of DNA, and a positive response, better overall survival after treatment with an immune checkpoint inhibitor. Now, this data did not hold up, possibly because of multiple different DNA platforms that were used, so there was no consensus opinion that has been derived thus far. It's still a promising area of research, but it's not quite ready for prime time. For now, we're still stuck with simple IHC staining for PD-L1 expression. Well, how does this new immunotherapy Predictor compare to chemotherapy? That was answered by KEYNOTE 042, an open-label phase 3 study of first-line Pembrolizumab versus platinum-based chemotherapy in patients with advanced stage 4 lung cancer, with any histologic type, PD-L1 expression of 1% or higher, good performance status, no untreated or unstable CNS metastases, and no autoimmune problems. Patients were stratified according to geographic region, performance status, squamous versus non-squamous cell lung cancer, and intermediate 1 to 49% PD-L1 expression versus 50% or greater PD-L1 expression. It was a large clinical trial with nearly 1,300 patients randomized 1-to-1 to receive Pembrolizumab 200 milligrams intravenously every 3 weeks versus a standard carboplatin-based regimen with paclitaxel for squamous cell cancer or carboplatin combined with pemetrexed for adenocarcinoma. The primary study endpoint was overall survival. This slide gives us the early top-line data of Kaplan-Meier estimates of overall survival. You can see in the panel on the left, patients who had a PD-L1 expression of 50% or higher had a highly statistically significant and meaningful improvement in survival compared to the best platinum-based chemotherapy regimen, with a hazard ratio of 0.69. Patients who had a PD-L1 score of 1 to 49% had a hazard ratio of 0.92, with a 95% confidence interval of 0.77 to 1.11. This is not a non-inferiority study, so although the outcomes appear very similar, we can't say that treatment with an immune checkpoint inhibitor is equivalent to platinum-based chemotherapy, but this was a provocative outcome. The next question, from an evolutionary biology perspective and from an oncology perspective, is what happens if we use two predators on this malignant herd? Well, that was answered in KEYNOTE 189 of pembrolizumab plus chemotherapy versus chemotherapy alone in patients with metastatic non-small cell lung cancer. This study was in patients with non-squamous histology. There was a parallel study in patients with squamous cell lung cancer. All patients had archival tissue for PD-L1 testing, no untreated or unstable brain metastases, no autoimmune problems. They were stratified according to PD-L1 expression, according to whether they received a cisplatin or carboplatin-based regimen, and whether they were never smokers or former to current smokers. Patients were randomized 2-to-1 to receive pembrolizumab combined with cisplatin or carboplatin-based chemotherapy, or placebo combined with the same chemotherapy in a 2-to-1 randomization. The primary endpoint of the study was overall survival. This slide summarizes the overall survival versus PD-L1 expression. With this slide on the upper left, the Kaplan-Meier survival outcome of patients that had no PD-L1 expression, where they had a statistically significant improvement in overall survival with pembrolizumab plus chemotherapy, the blue curve, versus the red curve of placebo plus chemotherapy. Those who had a tumor proportion score of 1 to 49%, the panel on the upper right, there was, again, a statistically significant improvement in overall survival with the combination of pembro plus chemotherapy versus placebo plus chemotherapy with a hazard ratio of 0.55. And in the bottom panel, for those who had very high PD-L1 expression, an outcome that appears maybe a little bit better than would be achieved with pembrolizumab alone, but we couldn't answer that, of course, from this study. We would need a head-to-head comparison. Nevertheless, there was a highly statistically significant difference favoring immunotherapy, pembrolizumab, combined with chemotherapy, compared to placebo plus chemotherapy with a hazard ratio of 0.42, a 58% decreased risk of death with the combination. Well, that brings us to the NCCN guidelines that have been derived based on these studies and other studies with other immune checkpoint inhibitors that target PD-1 or PD-L1, such as nivolumab and atezolizumab. For those patients with very high PD-L1 expression, treatment with pembrolizumab alone is the preferred treatment, although chemotherapy combined with pembrolizumab also has Category 1 evidence support with a higher response rate and could be considered for patients with a higher disease burden, higher symptom burden, or patients who are fitter and can tolerate the increased adverse effects of being treated with an immune checkpoint inhibitor plus platinum-based chemotherapy. For patients with low PD-L1 expression, either 0 or 1 to 49%, there's no question that the best treatment, whether they have non-squamous cell lung cancer or squamous, is to be treated with chemotherapy combined with the immune checkpoint inhibitor. Well, let's ask the question, how fast can wildebeests run? And the answer is 50 miles per hour. How fast can lions run? Answer is 52 miles per hour. Well, there's some evolutionary evidence that suggests that wildebeests were not always this fast, nor were lions. The slowest wildebeests were systematically eliminated from the genetic herd by lions who ate them, and wildebeests became progressively faster over centuries of evolution. Also, in the same respect, lions became faster, because if you were a slow lion, you didn't eat. So lions became faster. This is an example of coevolution. Well, we can ask the question, what happens as lung cancer, our wildebeest, with its intrinsically high mutational rate, evolves, runs faster? Can our activated immune systems activated by an immune checkpoint inhibitor, can they co-evolve? Well, an answer comes from the KEYNOTE 001 updated analysis. Not a firm answer, but a suggestion. Remember, 94 of the patients entering this trial had not received prior chemotherapy. When we look back now through the lens of over 5 years of follow-up, notice that among those who responded to treatment, it if they had greater than a 50% expression of PD-L1, that 30% were still alive at 5 years of follow-up, 29.6%. If their expression was low in the 1 to 49% range, then 15.7% were alive 5 years later. These survival outcomes are unprecedented in patients with stage 4 non-small cell lung cancer, treated in this case with a single drug, Pembrolizumab. We also have a suggestion from a clinical trial with nivolumab. Nivolumab was the first immune checkpoint inhibitor approved for the treatment of lung cancer in patients who had already received standard platinum-based chemotherapy. The standard of care for those patients was docetaxel. In this study, they were randomized to docetaxel or nivolumab. Among the 19% of patients who responded to nivolumab, this slide demonstrates that 54% were still alive 4 years later. Among the 11% who responded to docetaxel, only 12% were alive 4 years later, perhaps also an indication of coevolution. Well, do lions only attack wildebeests? No, they attack zebras, giraffes, warthogs, etc. And so it should come no surprise to you, who are now all evolutionary biologists, that our activated immune system will attack things other than wildebeest, other than lung cancer. And there are, in fact, some occasional adverse events. Not as common as there are with chemotherapy, 86% versus 60%, and not often high-grade adverse events that occur in 43.5% of patients treated with chemotherapy versus only 14.2% of patients treated with an immune checkpoint inhibitor. And treatment has to be discontinued more often with chemotherapy than it does with immunotherapy, and there are more toxic deaths. Fatigue occurs with chemotherapy a little less often with an immune checkpoint inhibitor. But immune checkpoint inhibitors can produce other immune reactions, such as a skin rash, colitis that sometimes can be severe and life-threatening, hypothyroidism, and something that's of great interest to all of you in this audience, pneumonitis, that occurs in over 3% of patients treated in this accrual of data from 8 clinical trials over 4,000 patients. Pneumonitis that occurs on biopsy is a lymphocyte-predominant interstitial pneumonitis that evolves to organized pneumonia with fibroblast plugs and foamy macrophages. One wonders if these are T lymphocytes activated by the immune checkpoint inhibitor. It occurs in about 3 to 4% of patients. It's increased occurrence to 4 to 6% when an immune checkpoint inhibitor is combined with chemotherapy, and up to 8 to 10% of patients will suffer immune pneumonitis if they're treated with an anti-PD-1, PD-L1 checkpoint inhibitor, or an anti-CTLA-4 checkpoint inhibitor. It usually occurs around 3 months or so after the start of treatment, but can occur a year or year and a half later, sometimes even after the immune checkpoint inhibitor has been discontinued. Grade 1 to 2 pneumonitis occurs much more often among lung cancer patients than among renal cell cancer patients or patients with malignant melanoma treated with the same anti-PD-1 or PD-L1 inhibitor. When you look at grade 3 to 4 toxicity, however, there's no difference among these 3 disparate malignancies, and there's no difference if one uses a PD-L1 inhibitor or a PD-L1 inhibitor. This slide summarizes the grading and the management of immunotherapy-induced pneumonitis. Grade 1 is asymptomatic immunitis that we happen to catch on a CT scan. Treatment can be continued. You could withhold it for a short period of time and monitor the patient closely with pulse oximetry and CT scanning. Grade 2 is mild to moderate, in which patients are symptomatic such that it limits their activities of daily living. Treatment should be discontinued and the patient monitored closely with serial pulse oximetry, repeat CT scans, and consideration of a pulmonary or infectious disease consult. Patients can be treated with steroids to try to cool down this immune reaction. Grade 3 includes patients who develop severe symptoms, where it limits self-care. treatment is discontinued, patients have to be hospitalized with oxygen supplementation, serial CT scans should be performed, pulmonary infectious disease consults are really mandatory, and patients should be treated with high doses of steroids. Grade 4 represents life-threatening respiratory compromise, in which, again, treatment is discontinued, patients have to be intubated with pulmonary infectious disease consults and treated with high doses of steroids with the possible co-administration of powerful immunosuppressives. Well, can lions be tamed? Can our immune systems be tamed? Well, sometimes. Siegfried and Roy had long careers in Las Vegas with their white tigers. Roy was mauled in 2003 by one of his favorite white tigers, but he survived. Unfortunately, subsequently died from COVID-19 in May 2020. That's a typo on the slide. Well, we found that in patients who develop grade 1 to 3 pneumonitis and completely recover, that we can successfully retreat them, re-challenge them with an immune checkpoint inhibitor about 50% of the time. So, lions can be tamed, in this case, about 50% of the time. This has to be approached, obviously, very cautiously. So in conclusion, lung cancer is one of the most genomically diverse and deranged of all cancers. Genomic diversity and stability explains in part the enormous variation in patient response and outcome following treatment, whether it's surgery, radiation therapy, chemotherapy, or newer modalities, and successful evolution to treatment resistance. Technology to identify and subclassify lung cancers is rapidly advancing and ushering in the era of personalized cancer care. Development of drugs targeting oncogenic driver mutations that occur in the genomically less complex lung cancers in non-smokers, a topic that we did not cover in this lecture, has been rapidly and highly successful. These are the patients with mutations in EGFR, rearrangements in ALK or RET, BRAF mutations, who are highly responsive to oral tyrosine kinase inhibitors. Identifying the similar driver mutations in smoking-related lung cancer has been more difficult, perhaps because of the huge number of genomic alterations that occur, but success is likely as science continues to advance. Immune checkpoint blockade, the topic that we covered today. Our greatest success has been achieved in the most genetically diverse cancers: lung cancer, melanoma, renal cell cancer. Our immune system, once activated, may be able to overcome lung cancer's intrinsic ability to evolve genomically and perhaps drive it to extinction, at least in some patients. Thank you for your attention.